like those debates. I usually lose them most of the time, but it's always worth trying. So, but I think this one, maybe I'll make a good point about it. So the following had been modified. I think originally, Amy and I had much more intense debate than this. We kind of modified it for the audience. I think the views may not reflect the presenter opinion. That's particularly what Amy is going to tell you, not mine. And I think at the end, you are going to conclude that intermediate risk revised IPSS should be regarded as a higher risk disease. So like when we talk about risk in most of the diseases, and as you heard even in myeloproliferative neoplasms, we are often talking about the risk of mortality from the disease, and in MDS particularly talking about risk of AML transformation. Why is that important? Obviously, knowing the risk provide prognostic information for the patients, caregivers, and the treating physicians. And the most important thing is probably the risk stratification. Currently, we still have only probably one procedure that's effective in MDS, allogeneic stem cell transplant. So we are always weighing the benefit of the procedure versus the risk of the disease versus the risk of the procedure. And as we develop more active therapies, that could change. And it's always important to remember that not every prognostic factor is predictive factor for treatment as well. So for many years, we used the IPSS, and we've moved on to the revised IPSS, which is definitely a refinement from the IPSS. It has better predictive prognostic utility. The cytogenetic risk groups are more expanded in the revised IPSS. It allows, accounts for the depth of cytopenia in MDS. So if a patient had platelets of 20 or 90 in the IPSS, we looked at them the same, while in the revised IPSS, we weigh a little bit on the depth of cytopenia and also account for the blast percentage in a little bit more detailed way. And those are the cytogenetic risk groups, much more detailed. Again, nobody is expected to memorize those, but we learned few things like deletion 7 is better than monosomy 7, for example. If you look at the patients that had intermediate risk cytogenetics, those are around, probably 20% of the patients with a median survival of 26 months, just based on the cytogenetics. Now, once we get the lump score for those patients based on the blast percentage, the cytopenias, and the cytogenetics, the revised IPSS divides the patients into 5 groups, the very low, low, intermediate, high, and very high. So we created this new group, intermediate, that did not exist before. And the question is always how to deal with that group. Do we manage them as a lower risk or higher risk? And that's most of the time really is individualized based on the patient, other factors, disease characteristics, age, etc. So if you look at that subset of patients, around 20% of the patients of MDS would be risk stratified as an intermediate risk by the revised IPSS, with a median overall survival of around 3 years. And this is our experience when we tried to validate the IPSS revised when it came first. And I don't know if this is working, the pointer. Here. So this is the original, IPSS revised by Dr. Greenberg. This is our experience. In this cohort, mostly untreated patients. Our group had mostly treated patients. And you see, unfortunately, that probably the outcome is still the same, even with the treatments we currently offer for patients. But validating that those patients with a intermediate risk had a median survival is around 3 years as well. There was this abstract presented at ASH looking at a cut point of 3. So basically, actually, the intermediate risk is considered 3 and above points, some score in the revised IPSS. So below 3 is a low risk. So this looked at if you just include the intermediate risk as a higher risk group, can you, see difference in survival? And the answer is yes. Obviously, the median overall survival was 13.9 months versus 61 months based on that cut point. But that basically is considering everybody intermediate as a higher risk. There had been subsequent publication on identifying the 3.5 score as the score that can distinguish or could be a landmark between what we consider a higher or a lower risk MDS. And this is, again, like this is how sophisticated it gets. So now we have a prognostic model for the intermediate risk IPSS revised. So a prognostic model for a prognostic model. I think we really need active therapies in this disease to stop doing all those prognostic models. But this is work from the MD Anderson group that we actually validated, and it's in press for publication. So they looked at the intermediate risk patients. And in multivariable analysis, the age, presence of circulating blasts, and transfusion dependency were the factors that they could use to risk stratify patients into two groups: favorable intermediate risk or unfavorable intermediate risk. And you can see this is the original cohort from the MD Anderson on the left, where around 54% of the patients came into that unfavorable intermediate revised IPSS. And then on this side is our cohort. We had almost 600 patients in the intermediate risk. Around 73% of them were classified as unfavorable. And with the median survival, again, was around 30 months for those groups that are classified as unfavorable. So you can look at certain features. People have suggested looking at the LDH, ferritin, fibrosis. So there are certain factors that will make patients higher risk. Now, how about complementing the IPSS revised or the IPSS with somatic the gene mutations? I think you've been hearing since morning about next generation sequencing, integrating that data. There is a paper by Rafael Behar several years ago looking at least 5 genes, saying that the presence of any of those will upstage the patients in the IPSS. And it holds true for the revised IPSS, so presence of any of those mutations will upstage patients. And if you look at the number of patients that were upstaged, around 33% of the patients had at least one of those 5 somatic mutations. And this is work, again, that Rafael Behar had presented on behalf of the IWG molecular group. They looked at the genes that are mutated and had an impact when they adjust for the revised IPSS. So in this group here are the mutations that will upstage the patients. And if you look at the percentage, around 35% of the patients that had blast less than 5% had at least one of those mutations that had impact in their outcome adjusted for the IPSS revised. And when you look at the patients that had 5 to 30% blast, the mutations were different actually a little bit, including, for example, P53, FLT3, EZH2, but again, the same theme that you probably can upstage around 1/3 of the patients based on the somatic mutation. So we know that that intermediate risk group, their median survival is 3 years. We know that majority of them actually have other features that makes them higher risk. So the question, so what? Do we manage them as a higher risk? Is there evidence for earlier treatment for those patients will make a difference in the outcome? We don't have, obviously, randomized clinical trials looking at that group. This is work by the Italian group looking at a Markovian decision model, similar to the papers published by Cutler et al. At the optimal timing of allogeneic stem cell transplant for patients with MDS based on the IPSS risk. It was a complicated model. They considered patients to be in different states, lower risk, moving very low, low, intermediate, high, and very high. And they had different scenarios. And what they do in those decision models, they look at the potential maximum gain of survival based on the timing of the transplant. So here, if you see, if patients are in a very low or low risk, the very low risk, actually, they did not even include. If they are in the low risk IPSS group risk, so the maximum gain of survival is actually waiting. This is the delay from the time of diagnosis. So in somebody who's younger, the gain of survival is almost 4 years from transplant if somebody waits. However, if you look at the intermediate risk group by that Markovian model, for any age, the maximum gain of survival is always when they proceeded to transplant early on. Again, this is Markovian decision model. This is not real patient data. And the maximum gain of survival kind of declined as we delayed timing of transplant for those patients. They also looked at integrating the benefit of hypomethylating agents prior to transplant in that paper. So again, this is the intermediate and this is the high risk group. This is with and without hypomethylating agents. And you see that there was suggested advantage for hypomethylating agents prior to transplant, and again showing that patients with intermediate risk group, particularly the younger patients, the benefit or the maximum gain was earlier on if those patients proceeded to transplant. So do patients with intermediate risk benefit from hypomethylating agents? Again, those are very difficult questions to answer in a retrospective fashion. I pulled, again, data from our database just to try to look at that. We had almost more than 600 patients that were labeled intermediate risk, and around 398 had received hypomethylating agents, and the median overall survival for those patients was 38 months versus 29 months. So there is a trend for better outcome or survival for patients with intermediate risk when they got hypomethylating agents. Obviously, this is a very biased way of looking at the benefit of hypomethylating agents, because we know that those patients were intermediate risk at time of diagnosis. We don't know what there was the risk when they got the treatment, and we don't know what was the indication to treat those patients. So probably the patients that did not get hypomethylating agents could be patients that were older, subsequently, unfortunately, transformed to AML or did not get treatment, or it could be the other way, that the patients that received hypomethylating agents were more cytopenic, needed treatment, while the other patients were more into the favorable intermediate risk. So it just really a very, very inaccurate way to try to look at the benefit of hypomethylating agents in that intermediate risk group. So I think, in conclusion, around 20% of the MDS patients, when we risk stratify them, they will fall into that intermediate risk group. And the median overall survival for those patients is 3 years. When we look at that intermediate risk group, majority of them actually would have some high-risk features, whether their score is probably more than 3.5, if based on that blood paper, whether they have some of the unfavorable features by the MD Anderson model, which is presence of circulating blasts, transfusion dependency, or by presence of some somatic mutations. 1/3 of those patients will have what we call a higher risk somatic mutation. And at least the Markovian decision model suggests maximum gain of survival for those patients with early timing of transplant in the intermediate risk group. I'll stop here. This is the Moffitt MDS team, and thank you for listening.